So thanks for coming. We have one of our third-year psychiatry residents who's been rotating with us all year long, Harshita Pinnamaneni.
Oh, you said that perfectly.
Oh, there we go. Finally.
We never have.
Who's going to present a journal club for us today. And I will pass it over to her. Well, let me just go ahead and share for you. In the window. There we go. Okay, can you guys see that?
Yes.
Okay. Here's the logo.
Oh, uh-oh. Did I say something?
Nope, it's still sharing.
Should I go ahead and look those? I know James is on the way.
We're at 12:07. Yeah, I think we can go.
Yeah.
Go ahead and get going. Then finish
Okay.
up. So
Um,
you can hide that side view if you want.
Oh. Okay. Yeah, so I found an article on rTMS for alcohol cravings and alcohol use disorder. And I thought this was like a good overlap between psychiatry and substance use, as well as we use rTMS now, I think primarily for treatment-resistant depression. I think it is approved for OCD. What I read, I can't remember if it's the deep coil, I think. But in terms of the substance use that I've read so far is, I think the deep coil or the H4 coil is approved for cigarette use or nicotine use only. But not for vaping. I think it was just for cigarettes. But I can kind of go, I have pictures, which might help with visualizing too. Yep, no financial disclosures. So learning objectives. So what is the current understanding of neuromodulation for substance use disorders? A review of rTMS, and a review of the study that I was mentioning, looking at the immediate and sustained effects of multiple rTMS sessions on alcohol cravings and alcohol use disorder. So I apologize if this is a review. I think this was more for me as well, but kind of going over the neurobiology of addiction. So as we know, prolonged exposure to addictive substances can affect multiple circuits in the brain, including those involved in reward, salience, motivation, inhibitory control, learning, and memory consolidation. And then neurocircuit-based interventions, such as neuromodulation interventions, can help target different neuroanatomical structures within these circuits. So here's a brain. And as we know too, there's different areas involved in that we're involved in cravings, such as the orbital frontal cortex, the medial prefrontal cortex. And then for the actual like binge intoxication part of it too, you have like the thalamus, the globus pallidus, and the dorsal striatum, which are heavily involved in the habituation part of it, and the ventral tegmental area, the nucleus accumbens, for the reinforcement part of that. And then in withdrawal too, the amygdala is a huge part of that, and the negative kind of affective state, anxiety, depression, and also the neuroendocrine system as well too, I think is important, like the hypothalamus, the corticotropin release stimulating hormone, I think I got that right. And the cortisol system, just for examples. But I'm bringing this up too because it can kind of help with understanding the areas that are targeted in neuromodulation and rTMS. So some background, I read different numbers for this, but so I said up to 50% of alcohol use disorder patients may return to use within the first 2 weeks following withdrawal management. Non-invasive neuromodulation techniques such as transcranial direct current stimulation, and I have a photo of that too. Non-invasive vagus nerve stimulation, rTMS, or repetitive transcranial magnetic stimulation, have been gaining more attention. And then I think with a lot of the studies, like with DBS and VNS too, there are limited trials. Recent meta-analyses have shown possible benefit with TDCS and rTMS and tobacco, alcohol, and stimulant and opioid use disorder, and also possible superiority of rTMS for alcohol use disorder and tobacco use disorder. And there might, as I mentioned, there might be possible benefit with TVS and cravings and consumptions with these disorders, but the data is pretty limited. And also too, it's important to note that most previous data for rTMS has focused primarily on the left dorsolateral prefrontal cortex. And that's often the area that we target for like depression and anxiety for when people go to the clinic for treatment-resistant depression as well. And yeah, this has been gaining more attention. So that's what the focus of the article is. So so with previous meta-analysis too, there has been a lot of limitations, such as pretty significant heterogeneity with the studies too. And also just, there hasn't been a lot of evaluation for follow-ups, rather than just the immediate cravings. And there have been more studies published since more recent meta-analyses, and this one will include those. And as I mentioned too, none of them have looked at the sustained effects of rTMS and alcohol cravings and alcohol use disorder. So what is TMS? So I think like going back to physics class, I think it's Faraday's law. I said the right one, but looking at changes in the magnetic field and how that can cause create an electric field, which can cause like the increase like the neurotransmitter release here through the electric currents. So and high frequency TMS, it's applied pulses in multiple trains to stimulate the underlying brain region. It's kind of looking at this multiple trains, which is why it's called repetitive. And that's been associated with effects that can last beyond the duration of treatment sessions. And then also too, there's something called theta burst stimulation, which was new to me too. And that's a modified paradigm of our TMS that use bursts of magnetic pulses, and that can elicit long-term synaptic plasticity. So here's an example of what that might look like. So you have the magnetic field inducing the electric field, inducing the electrical current, which can cause like neurotransmitter release in the brain. And then how they actually do it too is they'll to identify the region, for example, like the dorsolateral prefrontal cortex, they do kind of like a brain mapping. So they might do like a lower current stimulus and then to find the motor cortex, and that can cause like twitching in the hands. I actually had them do it on me too when I was a medical student, so it was an interesting experience. And then I think it's a certain distance from that is what they use to identify whatever the targeted region is. And then these are, let's see if I can, is there a way I can, or just this one? Oh, no, not that one. I'll just minimize this, I think. Okay, there, that works.
There's a way to get rid of it.
too.
I think that little, that button.
That one.
Yeah.
Oh,
There you
there,
go.
okay. Yep, so these are just some of the other neuromodulation techniques. So so transcranial direct current stimulation. So you have like an anode and a cathode, and I think it's like a low level direct current that's applied. And that also targets specific brain regions depending on where these are placed. And then DBS, so these are all invasive, the DBS, ECS, and VNS. And these can target like different like deeper brain structures, like such as like the globus pallidus, for example. This was actually new to me, the ECS, and I think it's like an epidural cortical stimulation, another implantable stimulating device. And then VNS, something that they also do not uncommonly at the St. Louis Park TRD clinic. Also invasive, and then what that does is it stimulates the vagal nerve, and that can affect neurotransmitter release, such as from the locus ceruleus, and I never know if I'm saying it right, the RAF nucleus. And yep, this is another example of the TDCS. And there's also too, as mentioned, like non-invasive vagal nerve stimulating devices. I do have patients too, even in the general clinic, that will just buy these online. So just kind of caution with that. Like, if you do come across patients that are using that, like make sure to look it up and see if it's, if that's been studied, and most of them probably haven't been. So yeah.
Build your own home kit. TMS.
Yeah, that's
Yeah.
okay.
Yeah.
I think the most part, like, I haven't seen like any like adverse effects happen from
Yeah.
the food, so like, I think just something to be aware of. Um. Yeah, so this is the article that, I looked
Sorry,
at.
Harshita,
Oh.
in terms of targeting, if you're comparing like the TDCS versus like TMS, is there one that's more like narrow in scope in terms of like more pinpoint versus more just general? I'm just curious in terms of the modality.
That's a good question. So I will say, I think this one, I think it also does target the same area. I'm not sure about like if it's even within that area, just so the dorsolateral prefrontal cortex, for example, if it's more targeted. So that's, I'm actually not sure. That's a good question.
It's more targeted. Things invasive is.
Oh, yeah, DBS, yeah, no.
Or TDC.
I'm saying TDCS versus TMS, one of the
Oh.
non-invasive ones. Is one of them like get a little bit deeper versus one a little more focused? Like, what, is there a reason to choose one over the other? But I'm kind of curious about.
I just know, like, I'm not sure if in terms of like how how specific the target is, but I think from the studies, like rTMS did show potentially more benefit from our previous studies with, I think it was saying alcohol, I'm pulling it
Yeah,
back up.
and
here,
tobacco, you
and
said.
tobacco,
Yeah.
Yeah, so I will say, actually I have a slide later on that I can show kind of looking at, the different coils of the TMS, like the deep TMS is kind of like the helmet.
Yeah.
And that does have like a deeper, I think it can go up as like up to 6 centimeters in
Okay.
terms of depth versus like the, what I just kind of refer to as like the regular. TMS is just more like, I think like 0.6 or something like that.
Okay,
So that's a little bit deeper, I think, but I'm not sure about TDCS.
fair enough. Thank you.
Um,
I know Jasmine is using TDCS
Yeah,
okay,
that's what I'm kind of just wondering. Yeah.
for
that's
her opioid alcohol studies.
oh, I'll have to look
Yeah.
at- I'll look more. Oh, for meth too. Yep, so this was a meta-analysis. So that-
First, do the ultrasound too. Have you seen the ultrasound studies, the focused ultrasound? You know,
about that, but I haven't
Yeah.
read it.
there's not much out there yet, but yeah.
So again, the aim with this is to look at the median up to 3 months effect of multiple rTMS sessions on alcohol cravings, specifically in alcohol use disorders. And then the method, so this is a systematic review and random effects meta-analysis, and I can go over what that means in a minute. So it looked at, they used a PICOS or PICOS framework with the patient population of individuals with alcohol use disorder. The intervention is rTMS for neuromodulation. The comparison with sham interventions, and the outcome is cravings post-stimulation, and then assessed by the study design, which is the randomized controlled trials, and I'll go more into that. And it used peer-reviewed research articles from these databases listed here. And you can see these are the key search words that were used for that. So TMS, theta burst stimulation, alcohol cravings. So the inclusion criteria, so peer-reviewed studies, looking at high frequency TMS specifically, and I don't know if I mentioned this before too, but it's believed that the high frequency TMS has more of an excitatory effect versus like lower frequencies has more of an inhibitory effect. And within the high frequency, they used, they're allowed for conventional rTMS. So that's kind of like that figure 8, more superficial kind of stimulating one. The deep TMS, and I'll have a photo of that soon. And that's kind of like the helmet that can go a little bit deeper. Continuous and intermittent theta burst stimulation, which as I mentioned was a modified form of TMS. And they use alcohol use disorder according to the DSM-5 and then the ICD-10. And then the study also had to include alcohol craving as either a primary or secondary outcome, using a validated or objective measurement tool. And one of the examples is the obsessive compulsive drinking scale. And it had to have a minimum number of 10 sessions of rTMS. As previous studies showed that fewer than 10 sessions didn't really have any significant effect on alcohol cravings. And they had to be randomized controlled trials using sham brain stimulation. And I was like curious about that. I was like, what does that even mean? So, and I think it has to kind of produce the effect that like someone receiving rTMS might have. So like it makes a clicking sound, or it might have like cause like a little itch, but or like be a lower frequency, but not necessarily like have an excitatory stimulating response.
And they did trials for a lot of these, looking at people couldn't tell the difference.
Oh,
Like
okay.
they actually surveyed them.
So,
The
yeah.
participants, they couldn't tell which one they got.
Oh, that's interesting. And then it had to provide mean standard deviation, the T effort, P statistics or other data that could be used to calculate effect size. And I think it uses standard mean difference to calculate effect size, and I'll go over that later. And then the inclusion criteria do not limit the tools used to assess clinical outcomes or the settings of neuromodulation intervention parameters. Oh, I thought this picture was kind of funny. So it was like from the international like OCD website, but this is the deep TMS coil. And I think in addition to targeting deeper structures, I assume it has like more like broader cortical effects. So less specific for whatever that area is.
It's kind of terrifying. I don't know.
Yeah.
No.
It could look very terrifying, so.
Is it actually what it looks like?
I think so.
Well, this is the deeper one.
The
Oh,
deeper one, yeah. The
The other one is a lot less.
Yeah, I think that's like the,
Ours don't look like that.
No, yeah, that's a.
yeah, this is what it usually looks like. It's a wand,
Yeah,
so.
yeah.
And even the wand, like the wand to head ratio is not that big, it's smaller, so. um, Yeah, so then the methods, exclusion criteria, so studies recruiting participants who don't meet the criteria for alcohol use disorder, so heavier drinkers, for example. Anything else that wasn't a randomized control trial. Studies assessing the neuromodulation effects but didn't measure alcohol cravings specifically. And studies that use techniques other than high frequency rTMS, so as I mentioned, like low frequency rTMS. And then that combined neuromodulation with other intervention methods, so CBT. Yep, for example. And something that I do want to point out here too, and I'll talk about this more in kind of like a future consideration, is it didn't account for like comorbid, like depressive anxiety, other like mental health conditions.
They were included though, but it could be included if they had comorbid.
Yeah, I didn't, which I think is kind of a big flaw. Or big consideration moving forward, I should say. So for each study, the following information is extracted: the author information, sample characteristic, study design, type of population, number of participants, stimulation technique, rTMS stimulation target, and then the total number of stimulation sessions, intensity, and then the duration between the last stimulation session and the follow-up evaluation, and then the measures used to assess cravings. And I have a table that may make it a little bit easier to visualize that or to understand that. So, and the primary outcome, so the relative change in alcohol cravings scores post-stimulation immediately, and then also in follow-up periods up to 3 months. And then for the data analysis, so a random effects model was used, and that was used to consider the underlying variability. And you can see that here too. There's a lot of things that were that were variable between the studies. And then the outcome variables, and then the standard mean difference, as I mentioned before, with 95% confidence intervals, was used to calculate the effect size. And then an I2 statistic was used to assess for heterogeneity between the studies or between the trials. And also important here too, a subgroup analysis was used to evaluate the effects of different stimulation areas. So the left dorsolateral prefrontal cortex, the right, and then the medial prefrontal cortex. And then a sensitivity analysis was also used by serially omitting each study from the meta-analysis to assess the robustness of the results. And these were the same follow-up effects that I had talked about before. So the results, a total of 12 studies ended up being included in the final analysis. 252 were randomized to the active rTMS and 223 were randomized to the sham group. And then these studies varied in length of intervention and follow-up period. And so the range of the total number of sessions ranged from 10 to 20. And as I mentioned before, a minimum of 10 was required. So 3 studies stimulated the right dorsolateral prefrontal cortex, 4 the left dorsolateral prefrontal cortex. 1 stimulated the left bilaterally, and then 3 stimulated the medial prefrontal cortex, and then 1 stimulated the insular cortex. And as I mentioned, high frequency, so I think above 5 hertz was used in all the studies, but there was variability between that. So 3 studies administered a theta burst stimulation, so which you can see that's much higher than the other ones, so 50 hertz. And then compared to like the 20 or the 10. And then 2 studies administered the 20 hertz and then the remaining administered the 10. And then all of them use the self-reported questionnaires or scales to assess alcohol cravings. So you can see the different ones listed here. And not all of them had the same follow-up kind of period. So 5 studies reported a 1-month follow-up, 4 reported 2 months, 6 reported 3 months, and then 2 reported 6 and 12. And here's the table too. So you can see there's variability in the number of sessions. So ranging from 10 to 20. It did look like the majority of them were 10 though. And then the variability in the frequency and the hertz too. And you can see the follow-up periods were kind of variable as well. And then the variabilities in the stimulation target and techniques. And then the different scales. Any questions so far? You know, I'm using a lot of like kind of acronyms to describe everything. So you can see there's quite a bit of variability in not that many studies.
Are you familiar with some of these specific ones or no? I mean, that would be a lot of work.
Oh,
I'm just curious,
like-
the Hoban study that just stands out to me as a higher N and a longer follow-up. I was curious what that particular result was.
I'm not familiar with the specific ones. I think,
I'll look it up. I'm just
yeah,
curious.
so-
Yeah,
you're saying like the high, like more follow-ups and then.
it had a higher number of participants. So I'm just curious. If I was gonna look at ones real
Oh,
quick, just to
okay.
see, am I, out of my
that's-
own curiosity, I'll look it up later. Yeah.
Okay.
yeah.
And then, so as I mentioned, total of 12 trials were combined. And then the effects of rTMS versus sham stimulation on alcohol cravings immediately after the last intervention showed, or the meta-analysis revealed a reduction in alcohol cravings after active rTMS in comparison to the sham stimulation. And you can see like the P is 0.04 here. So, and then the I2 statistic, as I mentioned, was the statistic used to measure the heterogeneity was substantial. So I think that is notable. And then there was no change in the combined standard mean difference after removing any of the studies from the meta-analysis. So indicating the stability of the results. So the maintenance effect, so I have it here for 1 month, 2 months, and 3 months. So so you can see here the P was 0.52. So maybe there was some approaching statistical significance for reduced cravings in the 1 month period or 1 month follow-up period. Interesting, the 2 months didn't find any effect or show any notable changes with that, but 3 months did, and it did have a medium effect size. I don't know exactly why that is, or if that's because of the variability between the studies. And then actually the follow-ups for the, I think 6 months and 12, since only 2 of the 12 studies included the later follow-ups, those weren't included in the standard mean difference. So you can see this didn't go over like the 6 month or 12-month follow-ups because there's only 2 studies that included that.
No, wait.
But it does say there that-
Oh, hang on.
But it's
None of
li-
the studies reported any beneficial effect of rTMS for more than
Maintained,
3
so,
months.
oh yeah, and that wasn't,
So
yeah,
only 2 studies went beyond 3 months, and those 2
And
studies
those 2 studies
did not show a
show.
sustained benefit beyond 3 months.
and then I think it did say though, it wasn't, okay, yeah, so thank you for for clarifying that. And I think it was, so the Hoban one, and then,
Something. That's it. Yeah.
I think to take over, yeah, the maintenance effect, and then, so looking at this, effects by the stimulated region, so, the medial prefrontal cortex actually had the highest standard mean, difference, suggesting like a higher effect size for that, which is interesting, so possibly, more benefit from targeting the medial prefrontal cortex, and kind of looking at like the brain from before too, like that is an area that's involved in cravings, so. So that was interesting, I thought. And only one studied the insular cortex. So conclusions. The The meta-analysis showed that rTMS compared to sham stimulation had immediately decreased alcohol cravings in individuals with alcohol use disorder after the intervention was administered for at least 10 therapy sessions. But then there was variability with the maintenance effect across the 1 month and 3 month follow-up period, as I've mentioned. And there is some evidence for difference between stimulation targets, with possibly more benefit for the medial prefrontal cortex. So it shows that this could be promising to even for longer term maintenance effects for cravings. And there were a lot of limitations with the studies. So a small number of studies that were actually included, the variability across like multiple aspects between the studies too, like whether it was the number of treatments applied, which it might be easier to go back to this table again too. So the stimulation technique, like even like the frequency that was applied to, like for example, is theta burst like more beneficial than just regular the other high frequency rTMS. And then yeah, the stimulation targets as well, like a lot of variability there. There's only a few studies included, for example, in the medial prefrontal cortex. Yeah. And then even too, there's variability between like the number of participants, as Dr. Peter pointed out in each study as well.
Was there any talk about other measures? I mean, they focus on cravings here, but was there any discussion in the article about like
Use.
outcomes? Yeah, in terms of use, heavy drinking, things like
So,
that.
and I think that was actually, they didn't talk too much about that as well. That was actually a suggestion for future directions to like looking at, you know, time to return to use, and then, relapse rates as well.
Okay.
So it was, the focus was primarily on cravings, or only on cravings. And then, so kind of, yeah, future directions from what I've read in this study and elsewhere as well. So looking at longer follow-up periods, so 6 months and 12 months, for example, having more robust randomized control trials, looking or having more studies on the different stimulated regions. As I mentioned, number of sessions too. And then also to what was interesting is I read about like utilizing like fMRI as well to actually see the underlying like neural mechanisms and the effects on the like while you're targeting that region. And then also I think this is pretty significant, like considering co-occurring psychiatric disorders. Like for example, I was even thinking about the patient today as well too, who if they do, for example, have like treatment-resistant depression, would they benefit more from this than maybe someone who doesn't have that? Yeah, these are just the sources. So yeah, I think that's it.
When you use it for depression, is it similar where you're not expecting like a lasting effect? Or is it not similar in that respect?
So I think often too, and Jamie, if you want to add in, how long do the sessions typically last? So they'll usually do like, thinking about ECT, but it's multiple sessions. 36. Okay,
But this is the same, 5 and 6 months to.
Okay.
yeah.
So they're more intensive than the immediate courses, I'm sorry, 36 sessions?
Yeah.
Or 4 to 6
I think-
weeks? 6 weeks,
It's daily.
It's daily.
Like 5
Yeah.
days.
right?
But I do know people often have to come back for repeat courses.
For maintenance.
For maintenance.
So we're thinking of it more, and this may be exactly the same thing, is that you do this, and 10 sessions is really short,
Yeah.
basically. And so there might be the acute course, but likely followed by maintenance sessions. I just pulled up,
Oh.
go ahead, Pam.
It's hard to hear the questions there, but what about for other disorders that this is used for? Is there evidence for long-term effects? Or was that just ask? Or, you know, like for OCD or depression?
Sorry, can you repeat the question? Is it like a currently being used for other use? Like, did you say use?
No, does that have longer term effects? Have they looked at whether using rTMS for OCD or for depression, do the effects last in those cases?
Yes, ma'am, they were just talking about that in terms of
Oh, okay,
just a depression, sorry, the psychiatry residents were talking about it. They do like 36 sessions, so more intensive, kind of do a daily, like 5 days a week,
Yep.
once a day, so longer kind of course, more intense. And then they have, up to 6 months to a year, but people do need boosters at times, so yeah.
okay.
Longer, but not like permanent necessarily, yeah. These are treatment-resistant depression people though, not just average depression.
Sure, yeah, yeah.
And it is used for OCD, but I think H4 coil, I was gonna double check, so that's the helmet one, I think that's the one that's approved for OCD. I'll have to double check that though. And then it has been, used for other substance use disorders too, like going back to the first slide, there is potential promising benefits especially for tobacco use disorder, but also for opioids, all of
Yeah.
them, basically stimulants.
So Dr. Kemchong here has done a series of articles on mainly TDCS. And what they've actually been looking at there is with some brain mapping, with MRI imaging, what regions change, people who relapse and who don't, and then looking at essentially doing repetitive tasks while they give the treatment.
Okay,
So it actually helps stimulate the region by like them activating it when they're doing this task. And then also using TDCS to either, strengthen or attenuate, and doing that in combination. So they're actually using that circuit while doing the treatment and having
Interesting.
potentially better outcomes that way too. So, and they've been doing stuff now in OUDs, so there's some interesting data that way too, about kind of pairing that.
yeah, that's really interesting.
And
Do
so-
we know anything about adverse effects from this? From the stimulation, or this neuromodulation?
I do think the risk of it, like, potentially like triggering a seizure is very low. I do think they consider that into the history, like the intake when they are doing that.
For seizures, did you say?
For seizures, but I think even that risk is pretty low. There's
Yeah.
no notable adverse effects that I'm aware of. I think if
Yeah,
someone
they
has a
use-
depression, a bipolar, yeah, some irritation. I know before too, if someone has a history of a mania, there is potentially a risk with triggering a manic episode, but I'm hearing lately too, or talking with the TRD team that it's not actually like a huge, that risk is pretty low as well. But insurance might not cover it if they have a mania history, or most likely won't cover it.
Yeah, and it probably doesn't cover it for alcohol use disorder?
No,
No. No, but if they have like a co-occurring, like treatment, like, they've tried a couple of medications for depression and that wasn't effective, then you might be able to get coverage. So, kind of.
For that, yeah.
right, and that's
Um,
an exclusion.
Some
Oh.
clinics exclude people with substance use disorders as part of it.
Oh, okay, I didn't
Sure.
realize that.
Yeah.
Okay.
So, but
and is somebody doing it there?
Yeah, TMS.
yeah, St. Louis Park, they do a lot of neuromodulation treatment it's part of the university.
Part of the university? Is it a special center or something for that?
Yeah.
Just like.
Okay,
It's part of our psychiatry department, part of our psychiatry clinic,
okay,
Yeah.
so it's a specialized clinic.
okay.
So are patients from Lodging Plus who go in these trials, they go out to St. Louis Park, or are they
No.
able to, they're do it here?
They do it here.
Yeah, so they're doing some stuff here too at this site,
TMS or the
TDCS.
Okay.
because they were taking them from Lodging Plus and doing the
Okay.
treatments for the study. So they are doing some out of this facility as well, at the West.
And
Huh.
it's portable, I mean, you can do
Yeah,
this.
that's
like,
the
do it at
idea.
Other treatment centers.
Yeah,
Yeah,
that's the hope, is that you could do it at the treatment center, right?
And you
could
can,
do,
and they
you
do,
could,
they
you
have.
could get the sessions in, right, while they're at the center. That's the.
yeah,
Right, they're doing it at New Way, for
Yeah.
instance,
they are?
they were,
Huh,
but are,
for research purposes, you mean, or
Yes.
actually?
a
for
research
clinical?
trial.
Yeah. we should-
Yeah, okay. Yeah. Okay,
So one
well,
of
it's interesting. I think the concern is, the longer term, is it really going to be effective long term? Obviously, alcohol and addictions are chronic diseases. If it helps for 3 months or even 6 months, that's great, but then what? So I think, it will really be important to do longer follow-up, as you said, you know.
I do hope it gets to the point where insurance covers it more too, and it's more accessible, because I think that's a huge barrier right now too. Like I had a patient today that the clinic, actually recommended, the TRD clinic recommended it. But there's just not that many sites that do it, and transportation is an issue. But otherwise, I think because like, there's not really any adverse like effects that are there, and the side effect profile is like pretty minimal. It's not invasive compared to some of these other neuromodulation techniques. There's potentially a lot of benefits with this.
Mhm.
So,
And even if you buy someone 3 to 6 months, that can mean a lot when it comes to recovery. So
Well, yeah,
there are ones looking at more than just cravings. Again, that's why I was talking about the other study. They're
Yeah.
actually looking at improving brain pathways that seem to be related to resiliency. So there might be some things we can actually strengthen.
I just,
yeah.
man.
Yeah, yeah.
Okay, so you asked a question about one of the studies, right? The one that was longer,
Uh-huh.
the Hoban study. So that did also look at abstinent days
Okay,
oh, okay.
I'm sure some of them did.
in addition to craving over a 6-month period. So they intended to look at 12 months, but they're only reporting on 6 months. So basically they're saying it did not, so this was a high frequency repetitive TMS in the dorsolateral. So which dorsolateral?
left.
Said,
I think they said the right dorsolateral prefrontal cortex. So that was there where they used this. This was a study that was done in Amsterdam in 80 detoxified and abstinent AUD patients in treatment. Okay, 10 sessions on 10 consecutive work days. So the TMS did not affect the number of abstinent days over 6 months.
Hmm.
The difference was 9 days. Moreover, it did not affect craving. And so their conclusion was that there's no evidence that high frequency repetitive TMS over the right dorsolateral prefrontal cortex had a long-term positive effect
Oh.
on or craving.
Okay.
yeah, that's why we look at multiple studies. But yeah, this one didn't find that. But I'm glad they included it.
I pulled up one of the other ones because
Yeah.
I meant to Google the meta-analysis and found the Errol study, and they actually found that it decreased the heavy drinking days from 10 to 2.9.
Oh.
So there was a pretty strong significance in that study. So
Mm.
I'm sure a lot of them looked at like
Yeah.
drinking measures.
Sure.
Maybe they just weren't
Yeah.
able to do a meta-analysis of it. It's that outcomes were different, abstinence versus like heavy drinking days.
Yeah,
And that's why I really think that the co-occurring disorders plays a huge role in this. Because, just kind of like what kind of brain, like pathways, like circuitries involved and,
Hopefully they did some
yeah,
matching
resilience.
a little bit or something with these studies, but I don't know. Yeah,
Yeah.
we have to look at
There
each.
might have been,
Yeah.
it wasn't really discussed like too much in the article, but another thing that I was interested in too is even with behavioral disorders as well, I was reading something about like, it was, have you heard of like Ashley Gearhart, and she does like kind of eating disorders, like binge eating and like kind of looking at like addictive pathways with food and like ultra processed foods. And then there's something where she did like an fMRI study, and then the activity was changed in like the orbital frontal cortex while like someone was drinking a milkshake. So I'm like, oh, that could be
Yeah.
like,
Oh, no, there's
like other behavioral study, like
gambling, a lot of things have some
gambling,
similarities.
yeah, so,
Mhm.
yeah, so
It's interesting. Um, it looks like this is one of those, things like people are gonna jump on the bandwagon and, hopefully not, without more evidence, but, it's being used for a lot, or tried for a lot of different things at this point, right?
insurance will come
Yeah.
anytime soon. You
Yeah.
can just buy it off of Amazon and then you're good to go.
Yeah.
I'm sure some treatment centers will
Yeah.
start just doing it themselves as a hook to get people in, which is not great, but that's happening with everything. But I mean, again, it's all in this neuroplasticity kind of frontier.
Yeah.
Yeah.
And there's promise there, so yeah.
And I know like for, in the TMD clinic too, a lot of the people who end up getting VNS also have like, mood dysregulation, like so cluster B traits, which is often happens with like alcohol use disorder as well, and,
Trauma history.
like trauma history too. So, and I think it's been particularly like have you guys noticed this as well for people with kind of like a trauma history, like mood dysregulation, VNS especially? So,
I mean, even tip skills are nice for them, which
yeah.
someone is hooking into the vagus nerve, right? So that kind of makes sense, right? Yeah.
So and I do wonder if that's where kind of like it felt like an NVNS might have potential benefits.
Believe that.
But that's invasive, so.
Invasive for.
Yeah.
for-
Yeah.
So Jared, if you are interested in CME credits, can you put your contact info in the chat so I can make sure that gets to the CME office? Otherwise, I have Ingrid's and I know
Yeah,
Sheila and David. Is
yeah.
there anybody else there that wants CME?
No, I don't think.
Probably not.
You guys don't need it still in residency, yeah. You have a question, Lolita?
Oh, no, I just wanted to ask how, I have patients for after the PMS and they call it nausea. Oh, already.
So one of our residents said they had some patients with TMS treatments who were having nausea. That was pretty significant as a limiting factor. So,
Okay. With the procedure, you mean, like,
But you give so bad and stuff, but it's like overall a pretty like bad experience.
like they would stop treatment
Yeah,
because of
They
it?
stopped treatment because of it.
Okay, gotcha, good to know. So they would even give Zofran, but some people stop treatment because of the level of nausea. Gotcha.
okay,
People stop treatment because of side effects of naltrexone and everything else all the time. So yeah, it's a pyramid.
yeah,
That's ours.
Yeah, so fair, we can wait all together, yeah. Any other questions or comments? Or
mhm. Thank you, Harshita. That was very interesting and
And
nice
next
job.
Thank you.
next month, I think Jared, if this is Jared Hopkins, I'm guessing is on, I think is gonna do one potentially still on ketamine. But. that's
Oh, good. Okay.
All right.
Yeah.
Good.
To make sure, all right, thanks, Jared.
Right.
Ingrid, should we call you or could we call you in just a few minutes?
I'm gonna stop recording.
Yes, that would be fine.
Okay, we'll do that.
All right. Thanks a lot, everyone.
Thank you.